and policy on the modern usage of fear-based prevention messaging. He holds a Bachelor's of Arts degree in political science from the State University of New York at Buffalo and a Master's of Public Policy as well. And then Emily Patton. Emily is also assisting Josh today. They're co-training today, rather. She's the research associate at Carnevale Associates. She offers over 9 years of expertise in data analysis, program management, and evaluation. Under the District of Columbia Department of Behavioral Health, she provides data analysis, programmatic support, and training and technical assistance for multiple contracts that serve youth and families in the district. She also serves as a research associate for the Prevention Technology Transfer Center Network, Central East region. However, they're also working today with the Southwest region. In her role, she provides expertise in substance use prevention, mental health, and program management. Prior to joining Carnevale Associates, she worked with CSR Inc., serving as the lead analyst for the Edward Byrne Memorial Justice Assistance Grant Program, which is the largest source of federal justice funding in the country under the direction of the Bureau of Justice Assistance. Emily holds a Master's of Science with merit at Abnormal and Clinical Psychology in Swansea University and postdoctorate diploma in criminology and criminal justice from the University of Edinburgh. The Southwest welcomes Mr. Josh Esserick and Ms. Emily Patton. I'll turn the time over to you all.
All right. Thanks, LaShonda. Hi, everyone. I sincerely apologize for all the tech issues we had this morning. I think it's all my fault, unfortunately, but hopefully it's all doing all right now with Zoom, and I think I'm successfully sharing my screen now. So before we get started, I'm going to try jumping into things very quickly because we already had a lot of content we needed to fit in today, and now we unfortunately have a few less minutes, but a couple quick notes before we get started. First of all, if you have any questions at any time, please feel free to type them into the chat, and either Emily or myself will do our best to answer them as we see them. We're also going to try to still fit in a Q&A period at the end of the webinar, where you can hopefully get a chance to ask some questions then as well. In addition to that, there's a few questions we're going to ask you all throughout the webinar to get your thoughts and opinions on some of the different things we're talking about. And if you'd like to respond to those, or if you want to comment on any of the things we're talking about, please feel free to use the chat for that purpose as well. And lastly, as I said, we have a lot of content to get through. And so because of that, and because we got the slightly later start, a few of the slides we are going to go through rather quickly, especially some of the data slides where we're mostly just going to focus on the key takeaways rather than trying to read out all the data on the slide. However, my understanding is these slides are going to be available to you after the webinar is over, so you'll be able to look at them at your leisure as well if you want to look more closely at any of the data that we're talking about today. So our learning objectives for today are, first of all, we're going to briefly talk about just why emerging trend data is important, why we should care about it, and talk about some of the data sources we can use to be identifying emerging trends. We're then going to spend the bulk of our time today talking about and determining what are the regional emerging trends we see in the Southwest, using a variety of different data sets. We're also going to talk about what we know so far about the impact of the COVID-19 pandemic on substance use. There's not as much data available yet on that, unfortunately. After that's done, we're going to talk a little bit about some of the different factors. We're going to talk social determinants of health that can help explain why we see different variations in trends by geographic, demographic, and cultural differences. And as part of that, we're also going to talk a little bit about some strategies for addressing drug trends. So it's a lot of content to get through, and let's jump right into it. First of all, by talking about data sources for identifying emerging drug trends and why we want them. Also, I am originally from the state of New York, so I sometimes talk very quickly. I do apologize for that if I do, but maybe in this case, it will be a boon to us since, as I said, we have a lot of content to get through. But if I talk too quickly, let us know in the chat. So first of all, why do we want emerging drug trend data? Well, we want it because it lets us be able to better identify and prioritize what our needs are in our states and communities. And it's something we should be doing as part of our needs assessments so that we can do proper strategic planning and figure out what is our comprehensive approach to prevention that's appropriate to the needs of the people we're serving. And all types of substance use data is important to that, and all types of data around capacity and community readiness to address needs and so on. But emerging drug trend data is a very important part of that because we always want to try to stop trends while they're still emerging, because before they become full-blown epidemics. And there are a variety of different epidemiological surveillance systems that we can use to help us identify these trends. Unfortunately, even though a lot of data sources do exist, and we are briefly going to talk about some of them, there are often challenges to obtaining that data. One big one is that data isn't always available at the local level. A lot of times it can just be national or state level data. Also, a lot of times there's a data lag. A lot of the data we're going to be talking about today only goes through the end of 2019, which in most years would probably still be good enough to help us have a pretty clear picture of what's been going on. Unfortunately, 2020 had a seismic event that is still happening with us now. Now, because the COVID pandemic's been so big, there has been some one-off and additional data collection so we can try to get some more timely analysis of its impacts. And we are going to talk about that data. But a lot of the usual sources we have aren't going to be releasing 2020 data until this fall. So there is that lag that can sometimes hurt us as well. Also, sometimes there can be issues around data being siloed or not being properly provided to us. And there are a variety of strategies to sort of overcome these barriers, or at least try to. We don't really have time to talk about them right now. That's almost, in fact, is an entire separate webinar I've done in the past. But one strategy is to try to obtain emerging trend data and all substance use data from as many different sources as we possibly can, so that there are built-in redundancies in case one or more of them doesn't help us. So we have a handout. I don't know if there's a link available to it through Zoom. There was going to be a download pod in Adobe Connect. I'm sure it will be made available to you at some point after the webinar as well, if it's not available right now. But it provides a list of a variety of different data sources that you can use to try to identify the emerging trends specific to your states and regions. It lists what the resources are, so it gives them the name, a description, and a link to them. And hopefully you will find that useful. So moving on though, in addition to that, moving on. So those data sets that we listed are mostly national data that is national data sources that have some state and local data. But in addition to those national sources, anytime we're trying to find emerging trend data, we really want to be obtaining data from state and local sources if we can as well, to supplement what can come from those national data sets. And again, we have to recognize that there might be barriers that exist to obtaining that data. We can't really make a handout listing examples because every state is going to be unique to some extent, and every locality is going to be even more unique. But some examples of entities you could reach out to would be state departments of education or health or public health. State Department of Motor Vehicles might have drug-related traffic incident data, state police, the Office of State Courts, state liquor licensing agencies, prescription drug monitoring programs, medical examiners and coroners, county and municipal agencies, healthcare providers, schools and universities, and even very local stakeholders like parent-teacher associations or local business councils. Those kinds of entities might only have qualitative data and might only have a little bit of it, but it can still help fill in the picture of what are the needs in the community and what are these emerging trends we're seeing and what is the readiness to address those emerging trends. In addition to that, you can also potentially collect primary data yourself to try to learn more about what's going on in your community, most commonly through surveys, focus groups, and key informant interviews, which I know those have been rather difficult to collect over the past year due to COVID-19, which is actually a good transition to start talking about the impact of COVID-19. And as we do that, I actually do have my first question for you all. If you'd like to share in the chat, or an answer to this, which is what have your experiences with data collection been since the pandemic began? For instance, I know that a lot of places haven't been able to do their school surveys because those were always done in person, and a lot of schools were closed during 2020. So if you've been having any experiences like that, or been able to overcome those kinds of challenges, or had different types of challenges, would love to hear your thoughts on that in the chat. And as you hopefully are typing into that, because I actually can't see the chat while I'm the one sharing my screen because I only have a single monitor. I'm not fully in the tech age. Let's talk a little bit about the impact of COVID-19. So first of all, the big thing to know is there's not a ton of data yet about it because, as I said, there's this data lag. We do have some data available though, and it is mostly just national data rather than something specific to the Southwest region. So when we start talking about specific regional trends, we're mostly going to be looking at pre-COVID times. But in all likelihood, what we're seeing nationally with COVID is something we're going to be seeing in most states as well. So one big data point we have is that the CDC conducted a national survey of about 12,000 adults in June of 2020, and they released their results of that last fall, finding that 40.9% of respondents had reported at least one adverse behavioral health condition, which is quite a bit higher than is usually found. They also found that 13.3% of adults had started or increased their substance use to cope with pandemic-related stress or emotions. And they found that 10.7% of adults contemplated suicide within the past 30 days. Now, there were rate increases across all adults, but there were some specific populations that were being disproportionately affected. And there is a link to this survey in our references at the end of this webinar if you want to look at the data yourself. But the specific populations disproportionately affected included young adults, Hispanic and African American adults, essential workers, unpaid caregivers of adults, and those receiving treatment for pre-existing psychiatric conditions. The CDC actually did a follow-up study to this survey where they were surveying people from August through this past February, and they released their results actually just 2 weeks ago, maybe 3 weeks ago at this point, after we made these slides already, which is why we don't have them available. Although that survey either didn't ask about substance use or at least didn't release their data on that yet, so it's not quite as directly relevant, but they did release a lot of information on mental health conditions related to the pandemic. And of course, there's tons of connections between mental health and substance use. And they found even higher rates of mental health conditions, as well as unmet mental health treatment needs. So there's a lot of impacts going on. And another data point that we have is actually the fatal overdose data, which there's provisional data available from January to July of 2020. So really only covering the first 4 months of the pandemic. But it found that over the first 7 months of the year, there's been a 15.9% increase in fatal overdoses. Now, the fatal overdose rate nationwide had been increasing in 2019 already, and it has increased most years for a few decades now, though it actually went down a little bit in 2018. But the fact that it went up in 2019 suggests that it probably would have gone up in 2020 as well, at least to some extent. However, it's never gone up over 16% in a single year, and that's only through 7 months. So likely when we have the full year available, it will show an even higher increase in overdoses. And in addition to that, another impact we see from COVID-19 is that states have made a lot of policy changes related to legal substances, most noticeably alcohol, but also some states have made policy changes related to tobacco products. Some of the states with legalized adult recreational use of marijuana have also made changes around that substance. All of these changes have been intended to basically make it easier for adults to still purchase the products during the pandemic. However, it's something of an open question as to how well states are equipped to address potential underage access to these products because of the policy changes. And so there's the risk that we're going to see a lot of increased underage drinking, tobacco, and marijuana use via the pandemic. We're also likely to see just overall increased substance use as the rest of the new regular data sources come online for 2020, because the nature of pandemics increase the risk factors associated with substance use, things like feelings of isolation, anxiety, stress, and depression. They can also directly or indirectly impact people's physical health, which can lead to substance use. And pandemics, or at least COVID, has disproportionately impact at-risk populations that are more at risk for substance use already, which can further exacerbate things. However, we do also have to note that there's a few risk factors that might actually be weakened during a pandemic. Some research suggests that's the case, and we need to be aware of that so that we can better learn, who are the people that are going to be more likely to be misusing substances versus in the pandemic, so that we can, make sure we're focusing our resources as best we can. And an example of a potentially weakened risk factor is actually peer pressure to use substances, because we're not around our peers as much. However, that does mean we're more isolated, which can itself be a risk factor. So it's all connected. And we actually see that weakening risk factor potentially in the vaping data, which we'll be talking about a bit later, because vaping specifically, we actually do have some 2020 data for. So with all that said, let's now turn to the emerging drug trends that we have complete data for, which basically means let's now talk about where things were right before COVID began, because that's where we have all of the data available. And like I said, where we do have some additional COVID-related data beyond what I just covered, we will talk about it. But a lot of the rest of the data we have is, a snapshot of the quote-unquote before times. So to sort of help set a baseline, this slide just briefly summarizes what we're seeing nationally, and then after that, we're going to dive right into the region. So nationally, we're seeing increasing marijuana use occurring across all age groups. Also, the opioid epidemic is continuing to shift in most states. Prescription drug opioid misuse has been in decline for several years, and heroin use has actually started to decline in a number of states as well. And in a lot of states, overdoses related to prescription opioids and heroin have been declining too. However, fentanyl overdoses have been continuing to dramatically increase. And it's because of them that the opioid epidemic, at least in terms of overdoses, is continuing to get worse and worse. We don't have data on how widely used fentanyl is, partly because it's so often mixed in with other substances. So I can't give you like a usage trend data there, but the fact that the overdoses keep increasing suggests that the use of fentanyl is also increasing. Also nationally, we're seeing methamphetamine overdoses and use increasing in regions of the country that historically have not had methamphetamine use be a major issue for them, like the Northeast. And this has led to there being more of a national focus on methamphetamines. There's been a lot of SAMHSA grants in the past few years that have focused on opioids or stimulants rather than just opioids, because methamphetamines, which had been more of a regional issue in a few regions, is now becoming more of a national thing as well. Also nationally, and you'll note this is for 2020 because we have more data available, is that youth vaping finally stabilized. In fact, it actually went down a little bit from 2019. The question, and the big question, which we don't know the answer to yet, is whether this is a permanent change or just a temporary blip because of COVID. And we'll talk more about that later in the webinar when we get to vaping. Lastly, in regards to alcohol, you can see even before the pandemic, there were concerns about underage alcohol use increasing. However, adult problem alcohol use was actually in decline prior to the pandemic. So with that in mind, let's now start talking about the emerging trends in the South-Southwest region. And what we're going to be talking about today is alcohol. We're then also going to talk about drug-involved overdoses and then the use and trend data around methamphetamines, opioids, and cocaine. And then we're going to talk about marijuana use and tobacco product use and vaping product use, and also a little bit about fatal suicide. And then after we cover all of that, as I said back in the learning objectives, we'll talk a bit about what can cause these trends to vary, as well as some strategies for addressing them. And to kick things off, I'm going to be handing this presentation over to my colleague, Emily, who'll begin talking about alcohol. And I think I'm going to stop sharing my screen now so that she can share her screen and we'll be able to get started. Yeah.
Yeah, sorry, actually I'm having an issue sharing my screen. So if you wouldn't mind just sharing yours and I'll just tell you next slide. I'd appreciate it.
Yeah, no problem. Sorry about that.
Yeah, sorry everyone, as we're trying to work through these tech glitches today.
All right, share screen. Okay.
Thanks, Josh. If you can just head to the next slide.
Yep. Yeah, there we go.
Great, thank you. So hi, everyone. As Josh mentioned, my name is Emily Patton, and I'm really excited to be here with you today to discuss the emerging trends that we're seeing in the Southwest region. So the section I'm going to cover over these next couple slides, Josh and I will do a little bit of back and forth throughout the presentation, but the next slides I'm going to review with you are going to focus specifically on alcohol trends and what has been occurring over the last few years around this topic. The data that I'm going to go over with you was pulled from each state's epidemiological reports, as well as state reported data into the National Survey on Drug Use and Health, NSDA. Data provided from some of the states in the region had some more context around their alcohol trends. So that's why you might see me expound a bit more about some states over others as I go through the next couple slides with you. So what we generally have been seeing across this region is that overall alcohol use trends have been generally stable over the last few years. There may be some minor increases or decreases, but some of that is not always statistically significant once you dig a little bit deeper into the actual data. Types of alcohol use, such as binge drinking, overall use, alcohol ever used may vary a bit more depending on age, race, or ethnicity, or via even regional differences, such as urban versus suburban. But overall, there's been no sort of significantly large increases or decreases in the Southwest regarding alcohol trends. In terms of alcohol-induced deaths, we have seen those increasing across the region. This has been mirroring the national trend. So the rate of all alcohol-related emergency department visits in the United States increased 47% between 2006 and 2014, which translates to an average annual increase of about 100,000 alcohol-related emergency department visits. Nationally, we see that alcohol contributes to about 18.5% of emergency department visits, with about an estimated 95,000 people dying from alcohol-related causes annually, making alcohol the third leading preventable cause of death here in the United States. To pick a regional example, in New Mexico, we see that alcohol-related injury death, their rate of alcohol-related injury death in New Mexico was approximately 1.5 times the national rate. During their reporting period of 2014 to 2018, drug overdose, which includes alcohol, was the leading cause of alcohol-related injury death, which was above both alcohol-related motor vehicle traffic crashes as well as falls. Numerous other types of injury death are also associated with excessive alcohol use, particularly binge drinking. And in that state, males were more at risk for alcohol-related injury death than females, with Native American indigenous males having a particularly elevated risk. We're also seeing underage youth drinking, so for those aged 12 to 17, generally decreasing across the region. This, again, is on par with what we're finding nationally, with national findings demonstrating a decline in underage drinking overall. Nationally, from 2002 to 2019, the prevalence of past 30-day alcohol use decreased 41.1% for 16 to 17-year-olds, almost 55% for 14 to 15-year-olds, and almost 62% to 12 to 13-year-olds across the United States. This really isn't that surprising given the national and state level focus on youth alcohol use that we have seen in the last couple decades. There's been those large pushes to implement prevention programming, targeting youth drinking and substance use overall, using alcohol intervention and treatment when appropriate. We see that this has been done through specific programs targeting youth in schools, the larger community, those kinds of settings, as well as through social media campaigns, and then policy level changes as well, some of which I'll touch on a little bit later in the presentation today. We also see in the region that unfortunately alcohol death use rates tend to be highest amongst American Indian and Indigenous peoples throughout that region. For example, in Oklahoma, the Indian Health Service linked death rate for chronic liver disease and cirrhosis deaths was 3.2 times higher among American Indians compared to non-Hispanic whites in that state. And then in New Mexico, their data showed extremely high alcohol-related deaths among Native Americans and Indigenous peoples, more than twice the state rate for both males and females. Next slide, please, Josh. Thank you. And now I'm just going to transition just a little bit and talk about this slide regarding alcohol policy changes. We've all seen how COVID-19 has led to multiple policy and operating status changes in the last year across the United States for places that sell alcohol. One really good resource that has documented many of these policy changes has been the National Alcohol Beverage Control Association, also known as NABCA. And so they created several interactive dashboards that can help folks navigate these policy changes, including tracking opening statuses, like some locations reopened for outdoor seating, curbside pickup delivery, on-premise operations suspended, things like that. Also, for example, they also have a wealth of information on restaurant operations, which will vary state by state. In some states, we know that restaurants are permitted to sell all types of alcoholic beverages, beer, liquor, other spirits, and that they can go for off-premise consumption. And then we see that in other states, sale is restricted to only one type of alcoholic beverage or may be prohibited altogether. And so to capture the variety in this state code, they collected operational practices for restaurants by determining whether the ability to sell off-premise was already permitted in the state pre-COVID-19, so operating as normal, and then also identifying any new operational practices that have been permitted through COVID-19 policy changes, such as curbside pickup and delivery, which we've seen massive increases of. And then they also provide data on which states allow mixed drinks and prepared drinks to be picked up versus those that are manufacturer sealed only. And, as Josh kind of touched on a bit earlier, we've really seen a lot of all of this data change pretty rapidly as what we know about COVID-19 changes, as well as how the situation has changed. And so we're seeing differences as states and locales reopen or close back down due to COVID. So it's always still important to check in with your state and even your local government for more timely updates. But NABCA is a really great resource to sort of see where we are nationally, compare states, look at what the region has been operating under, things like that. And then once data is released for 2020 and 2021 around alcohol trends, we should hopefully be able to see how these policy changes at the state level and the national level have impacted overall use during and after the pandemic, as sort of we kind of head out of it over the next year or two. We know that some preliminary data show that there's a possible uptick in alcohol consumption. So really analyzing that regional policy differences can help provide us with some answers as to how access and how this sort of change in access due to these different policies played a role in alcohol consumption. Next slide. So here we're going to start getting into the data a bit more. I'll be briefly reviewing sort of the highlights and the larger trends of what the data shows us. As Josh mentioned earlier, please feel free to download the presentation and access the additional resources that we compiled for you so that you can do a deeper dive after the presentation today. Next slide. So here we have past month alcohol use for those aged 12 plus. So across the 5 states in the region, we generally see stability across the years 2016 to 2019. There is some variability. So for example, we see some mild to moderate reductions in alcohol use in Louisiana, New Mexico, and Oklahoma. And then in Arkansas, past month alcohol use reported a small increase. And then we see that Texas remained steady across this time period. Nationally, the prevalence of people aged 12 plus who reported drinking in the past month in 2019 was 50.8%. So we see that each state in the Southwest region was below that national average. Next slide. Great. So looking at past month alcohol use for youth, so those aged 12 to 17, we see that there were reductions in use among this age group for almost every state. New Mexico experienced the largest decrease in youth past months alcohol use, dropping 2 percentage points. And then the other states experienced decreases ranging from about 0.5% up to 1%. We see here that Texas was the only state among this cohort that experienced an increase in youth past month alcohol use, but albeit it's a small one of about 0.3%. So like I said earlier, generally we're seeing some stability. There might be some increases and decreases, some of which will be statistically significant and others that won't. So I'd really encourage you to do a deeper dive into that data as well. And then in regards to the prevalence of drinking, according to 2019 national data, we see that 9.4% of youths aged 12 to 17 engaged in alcohol use in the past month. And so based on that national information, we see that Louisiana surpassed the national average in 2019, and that Texas was also pretty close to that national average of 9.4%. So a question for you all, if you'd like to answer it in the chat, what do you think has had an impact on the increase or decrease in alcohol consumption across your state? Are there any initiatives that you've seen that may have been increasing or decreasing, or any circumstances that might have play a role? Next slide, please. And so now I'm going to move on to talk a little bit about what we've been seeing in regards to binge drinking. So when we talk about binge alcohol use, it's generally defined as drinking 5 or more drinks for males or 4 or more drinks for females on the same occasion. So for example, at the same time or within a couple hours of each other on at least one day in the past 30 days. So in the prior 30 days, so month. So the data in this chart looks at binge drinking habits among those age 12 plus. And so we see that from 2016 to 2019, there were decreases in binge drinking in Louisiana, New Mexico, and Oklahoma. These decreases were generally small, ranging from about 1% to 3% in New Mexico. And then we can see here that Arkansas and Texas saw some small increases in their binge drinking data, ranging from increases from about 1% to 2%. We know that nationally, the rate in 2019 for binge drinking was 23.9%. So 2 states wound up surpassing that national average, and that was Louisiana and Texas. Next slide. So excessive alcohol consumption is a well-known risk factor for mortality and has been causally linked to a variety of different diseases, conditions, and injuries, including alcohol-attributable cancer, liver cirrhosis, alcohol poisonings, etc. Alcohol-induced deaths, or deaths from dependent and non-dependent use of alcohol, as well as accidental poisoning by alcohol, have been increasing in the United States since 1999, with some differences that you would see by sex, age, urban, rural classification, as well as some other different demographic characteristics. So we're seeing from 2015 to 2019, there was an increase in alcohol-induced cause of death across each of the 5 states in this region. So using the crude rate, most states saw an increase of about 3 during that time period. However, New Mexico had the largest increase at 7.5 in their crude rate. And so the negative consequences of excessive alcohol use, for example, I'll pull from another state. So New Mexico again. And so the negative consequences are not limited to death, but can also be related to a variety of other issues such as domestic violence, crime, poverty, and unemployment, as well as chronic liver disease, motor vehicle crashes, and other injuries linked to issues with mental health, and as well as a variety of other medical conditions that I touched on a little bit earlier. We see nationally that 1 in 10 deaths among working age adults, so 20 to 64, is attributable to alcohol. And then in New Mexico, this ratio is twice as high at 1 in 5 deaths. So all of this kind of fits in with what we've really been seeing at the national level, where age-adjusted rates of alcohol-induced deaths among adults aged 25 and over were relatively stable from 2000 to 2006, but then increased 43% between the years 2006 to 2018. So what we're seeing here at these states is also mirroring what we're seeing generally at the national level. Next slide, please. And just to pull out some more data about alcohol use across the region, we decided to focus as well as on driving under the influence. So in New Mexico, New Mexico's alcohol-related motor vehicle traffic crash death rate has decreased substantially over the past 30 years. However, there are rate disparities that do remain, and both male and female Native Americans, Indigenous folks have elevated rates, especially amongst middle-aged males. Their data shows that in 2018, 4.8% of binge drinkers reported engaging in this risky behavior in the past 30 days, compared to only 0.8% of non-binge drinkers. So we're seeing in New Mexico that binge drinking is playing a role in driving under the influence. In 2018, driving after drinking was most prevalent in that state among middle-aged adults, with 1.2% of those aged 25 to 64 reporting past month drinking and driving. Additionally, men in New Mexico were twice as likely to report drinking and driving compared to women. In Arkansas, in 2017, the number of crash injuries and deaths related to underage drinking drivers was the lowest it had been compared with previous 4 years. So that's positive. And so they have been generally seeing a decrease in their alcohol traffic related crashes and injuries in recent years. In Oklahoma, they found that there was just over 2,200 fatalities resulting from motor vehicle crashes that involved alcohol from 2008 to 2017. The number of deaths per 100,000 residents decreased in Oklahoma and in the US between the years 2008 to 2017. However, the Oklahoma rate has remained above the US rate throughout that time period. So that continues to be something that Oklahoma is looking to tackle. In Louisiana, adults reporting drinking and driving has been increasing since 2012. In Louisiana, adults reporting drinking and driving has decreased over the last few years. We're seeing from 5.10% in 2012 down to 3.5% in 2016, based on their most updated data that we have. And then in Texas, adults reporting drinking and driving has been increasing since 2012. We see that in 2012, their rate was 2.2%. And then by 2018, it had risen to 4.3%. We also see that drinking and driving in Texas is higher among males and among those between the ages of 18 to 29. So at this point, I'm going to hand the presentation back over to Josh, and I will join you all again in just a little bit.
Thanks, Emily. Hi again, everyone. So now we're going to turn to drug-involved fatal overdoses, as well as then the use of some of these substances that can cause fatal overdoses. So this first slide here shows the total number of overdoses by substance cumulatively for the region for 2015 to 2019. And a couple things to note about this data. First of all, this comes from the CDC's Wonder system, which reports the National Vital Statistics System data, which is the death data that the states report up to the federal government. And that means there are a couple caveats with this data. One big one being that different state medical examiners and coroners might have slightly different definitions for how to classify an overdose versus a suicide, or classifying it as both. So the numbers basically aren't probably exactly what occurred in the states, but they're the best data we have and are likely very close to it. Also note that these categories that I'm showing here are not mutually exclusive. So for instance, if someone had in their system both fentanyl and cocaine, they'd be listed twice in this chart, once as a fentanyl-involved overdose and once as a cocaine-involved overdose. If you want just the total number of overdoses for a state or a region or zip code, there's a different way to calculate it, because if you just add these up, what I'm showing here, you will get some double counting. But what this is useful for showing is how prevalent various drugs are in overdoses. And something that stands out for this chart is, well, the fact that fentanyl is not the number one drug involved with fatal overdoses. When I look at emerging trend data for most states, when I do this kind of presentation elsewhere, usually fentanyl just has some exponential growth over the past few years, and it is going up in this region as well. But here we can see it is not overtaken methamphetamines, for instance. And while some of those methamphetamine overdoses likely involved fentanyl as well, the numbers don't add up to say that it's just fentanyl, because some of those fentanyl overdoses are going to be with other drugs. There's other reasons why the methamphetamine overdoses are going to be increasing as much as they have over the past 5 years. And we will be diving into that in a moment. The other thing to know about this chart, you'll see at the very bottom, we have a small number of cannabis-involved deaths, and those are, for the most part, likely going to be deaths where cannabis was in the person's system, but it was, and the medical examiner felt that for cannabis was to some extent related to the cause of death. However, likely there were other drugs involved as well that triggered the overdose. So a few things to note about this data is that there are some pretty important variations in fatal overdoses by demographics, and this is all specific to the Southwest region. First of all, the fatal overdose rate is nearly double among non-Hispanic compared to Hispanic populations. Fatal overdoses are generally calculated using a crude rate, which Emily also talked about with alcohol deaths, where it's normalized for population. So it's X number of deaths per 100,000 people. So if the number is 5, it means 5 out of 100,000 people experienced this. And it's a way of making comparisons across populations of varying sizes. So in the Southwest region, the non-Hispanic population had a fatal overdose rate of 16.7. The Hispanic population had one of 8.3. Another thing we note, though, in terms of demographics, is that African-American fatal overdose rates, which had been lower than white or American Indian rates, has now basically caught up over the past few years. So in 2019, that same fatal overdose rate for the white population of the region was 14.8. For African Americans, it was 14.2. And for American Indians and Alaska Natives, for any number of them living in the region as well, it's 13.1. And then for Asian Americans and Pacific Islanders in the region, it's 2.8. So quite a bit lower. Also, the male fatal overdose rate is about double that of females. It's 8.9 compared to 9.4. And the last thing to note about fatal overdoses is that about 10 years ago, they used to be more concentrated among sort of middle-aged adults. It's now much more evenly spread across ages 25 to 64. Most commonly, this kind of data is looked in 10-year intervals. So 25 to 34, 34 to 44, and so on. And at this point, each of those 10-year intervals is pretty similar to each other. It's not as concentrated as it used to be. Overdoses are also increasing among those under 25 and those over 64 as well. So it's definitely a problem for them too. It's still a bit lower than that 40-year range in the middle there. So actually, another question I have for you all, since we're talking about overdoses, is what overdose prevention strategies have you been implementing in your communities? So, for instance, particularly dealing with methamphetamines, because again, with some of the other states I talk with a lot, like in the Northeast, where it's fentanyl, on an exponential curve, the main strategy is naloxone distribution and education distribution. And naloxone would certainly be an important strategy in this region as well, because there are the opioid overdoses, but there are also these other kinds of drug-involved overdoses as well. So, and if you'd like to share any of your thoughts on that, please feel free. So getting into some state-specific data and more drug-specific, we can see methamphetamine overdoses per 100,000 people. Because of time, I'm not going to go too much into the data here. Again, you can look at it more closely after the presentation's over. But this does show for each state how the rate of fatal overdoses has changed each year from 2015 to 2019, and then a comparison to the national rate. Now, something important and interesting to do is to compare this data to the methamphetamine use data that we'll look at later in the presentation, because one thing that will really stand out to you is that New Mexico does not have the highest rate of methamphetamine use in the region. And in fact, they're about similar to the national rate. But we can see the number of methamphetamine fatal overdoses in New Mexico is quite a bit higher. And so then it becomes a question of trying to figure out, well, what is the cause of these fatal overdoses so that we can be better prepared to combat it. It might be an issue that methamphetamines in New Mexico are more likely to have fentanyl in them. It might be that there's a greater issue with accessing medical care for an overdose. It might be an issue that methamphetamine is more potent in New Mexico. And actually, we'll talk briefly about potency in a moment, in a few slides as well. This next slide is similar to the previous one, only it shows now the data for opioid overdoses, and again, comparison to the national trends. And it becomes interesting to compare this data to the use data that we'll cover in a bit, because you can see, unlike many other states in the region, Louisiana is seeing an increase in opioid overdoses over the past few years. But if you look at the use data for opioids, you'll see that the use of opioids and misuse of prescription opioids in Louisiana has been in decline over these 5 years, just like we're seeing in many national states. So then the question again becomes, why have the overdoses increased? And here we have probably a good guess as to what the answer is, which is, in this case, it is fentanyl, because when we look specifically at the number of fentanyl overdoses in Louisiana, we see they've gone from 38 in 2015 to 324 in 2019. So again, it's always good to look at all this data in connection. You don't want to just look at any type of overdose data. So yeah, and this next slide, again, same sort of data, but this time for cocaine. And you can see how nationally we've seen cocaine overdoses double over the past 5 years, whereas in the region it's increased somewhat, but we're not seeing the same kind of increase, which again speaks to why, well, partly speaks to why it's so important to look at your regions and at your states and localities rather than just looking at what we see nationally, because the national needs might not totally match up with our local needs. And something we actually see with cocaine is that cocaine use in each of the states in the Southwest region has declined, whereas nationally it's continued to be stable or even increase. So again, speaks to differences. So turning now to use and to trends data, beginning with methamphetamines, the number of people who have been using methamphetamines nationally each year has been increasing. And in the Southwest region, prevalence of past year methamphetamine use was higher in almost all of the states compared to the national prevalence. And as noted in 2018 and also in 2019 in New Mexico, methamphetamine was the #1 substance involved in fatal overdoses. In a couple slides, I'm actually going to be showing you the data, the actual numbers for each state. And we'll see that, again, there have been some declines actually in the past few years, but just the total numbers are still higher than nationally. So the next thing I want to briefly talk about is some data from the DEA. They put out an annual drug threat assessment, both a classified report and an unclassified report. I don't know what's in the classified report, but in the unclassified report, they pulled together a lot of data from various sources that you might already be familiar with, NISDA and sources like that, but they also provide some of their own DEA specific data, which can help give us some additional context, particularly around the supply of substances and availability and access to them. So the DEA has reported that seizures of methamphetamines are continuing to increase. In fact, overall methamphetamine reports, which is the language they use around basically how many drug seizures have they had that reported having a drug with them, has increased by 75% since 2014. So in other words, the number of drug seizures the DEA has done that included methamphetamines has increased 75%. The DEA also notes that most methamphetamine available in the US is now produced in Mexico and smuggled across the Southwest border, whereas around 15 years ago, much more methamphetamines was still produced domestically. And one impact that this may have had is that the DEA believes that the pandemic might have caused a temporary disruption in the supply chain of methamphetamines, which has potentially led to increases in the street price of methamphetamines, although they don't anticipate that it will last. Another thing that the DEA, cartels, yes, the language that the DEA uses is a transnational criminal enterprises, I think is what they call it, but yeah, it's the cartels. The DEA has reported that the potency of methamphetamine has increased from about 90% in 2016 to 97%. 97.5% in 2019. So it was always extremely potent, but it's actually gone up over the past few years, which could potentially be one of the reasons why methamphetamine overdoses have been on the rise as well, that people are using methamphetamines that are even stronger than what they're used to. This next slide shows changes in use over the past year for the states in the Southwest region. Again, in the interest of time, not going to dive any further into it beyond what I've said, but hopefully you can take a closer look at it after the webinar is completed. Moving on to opioids. So as I mentioned, what we saw nationally in terms of a decline of prescription opioid misuse has also been occurring in the Southwest region, including, as I mentioned before, in Louisiana, which saw an increase in opioid overdoses. Heroin use was also stable or declined across the states as well. As I mentioned, the issue is generally fentanyl, which lacks usage data. In fact, the DEA reports that about 42% of all fentanyl that they seize is already mixed in with other drugs, and an unknown amount of the other 58% would have also gotten mixed in before it was sold. So that's one of the reasons why it's so hard to get use data on fentanyl, because it's so often mixed in with other substances. Overall, though, the regional use rates of opioids are similar to what we see nationally, but as I mentioned, national overdoses are much higher normalized to population than we see in the region. So potentially that means even though fentanyl is a growing issue in the Southwest region, it just hasn't been as much of an issue as it has been elsewhere. The most frequent use of opioids overall is among ages 18 to 25. And similarly to methamphetamines, the DEA reported in July, so relatively early in the pandemic, that supplies of heroin and fentanyl may be under strain due to COVID-19. Although whether that will actually have an impact or if people will just pay the higher prices no matter what to still get it, we don't know for sure yet. This next slide shows past year prescription opioid use for ages 12 and up for the states in the Southwest region. You can see the declines, which are not enormous declines, but they have been declines. And these declines have been a continuation of trends that we've seen for a number of years now in most states. So yeah, as I mentioned, the opioid epidemic has been in a shift. As far as cocaine use goes, in the region, cocaine use was in decline, except in Louisiana, which I did see a slight increase from 2016-17 to 2018-19, which means that the increases in cocaine overdoses in the region are likely due to increasing use of cocaine mixed with other drugs. Whereas nationally, where we see the very large increases in cocaine overdoses, as well as increases in cocaine use, suggests that the issue nationally might be just purely cocaine overdoses. Again, with cocaine, as with opioids, use is mostly concentrated among ages 18 to 25. In fact, it's extremely concentrated among them. And actually, unlike the other substances I mentioned, the DEA reports that the cocaine supply chain has not been as affected by COVID-19 as some of the other drugs have been. And the likely reason why is that coca cultivation in South America has been skyrocketing for several years now, to the point that there's so much cocaine available that even if it's harder to get it across the borders, there's likely a lot of it already sitting in the US. And this next data point might not directly impact the work that any of us do, but I think it's just an interesting one to point out in terms of this supply. In 2013, there were 279 hectares of coca plant being cultivated, and a hectare is equal to 100 acres, so 279 hectares. By 2019, it was up to 936 hectares of coca plant. So there's this huge supply of cocaine that has been moving upwards for the past several years. And this next slide shows past year cocaine use, which we more specifically focused in on just those 18 to 25-year-olds, because as I mentioned, cocaine use is so concentrated among them. So that's why the numbers here are higher than we see with some of the other data I pointed out before. But of course, if you are interested in the overall use rates rather than just 18-25, that is all available through all of the same sources that we pulled this other data from, which again, those citations are all available at the end of the webinar. Also, I believe the slide notes themselves also have citations pointing out where the data was pulled for each slide as well. So the next thing is actually marijuana, which I am not talking about. Emily is going to be talking about. So thanks all again for listening to me, and I'll be back later. So Emily.
Great. Thanks so much, Josh. And hi, everyone. Excited to be back. And just wanted to say thank you so much for all of the incredible comments that you are putting in the chat. It's been really interesting reading through a lot of your strategies and ideas and what you all have been working on. And I see some questions. I'm trying to get those answered as quickly as possible, and then hopefully we can answer the rest at the end of the presentation. So as Josh said, the next couple slides I'm going to talk about are going to focus on marijuana use as well as tobacco and vaping trends. So we see specifically in terms of marijuana, we see across the South-Southwest region data showing that the increase in marijuana use is almost entirely due to adults aged 26 plus, who are the ones who have been significantly increasing or reporting their increase in the use of the substance. Oh, Josh, can you go back? Thanks. This differs from what we have been seeing at the national level, which has shown us that use of marijuana has increased overall, so similar to what we're seeing in the region, but the drive from that increase seems to be coming from youth and young adults, specifically those aged 12 to 17, as well as 18 to 25. Something that's really important to note is an important difference in regards to marijuana use, is that based on the new laws and policies that have been we've been seeing implemented over the last couple of years at the state level, we're seeing that almost 34% of United States residents now live in a state that has legalized recreational marijuana use, and this number is likely expected to grow. However, we see that no states in the South-Southwest region that we're covering today have done so, but in the larger South-Southwest region, Arizona, and Colorado have. Marijuana legislation is intended only for adults 21 plus, but with this increasing ease of access and its sort of new, legal standing, may further weaken norms that we've traditionally had against its use. So this could potentially lead to an increase in underage access to marijuana, which we have already been seeing with vaping and other e-cigarette products. Next slide. So past month data is more relevant than past year data for determining ongoing prevalence. Unfortunately, for many substances, it can be harder to find available past month data that's really good at the state level, but marijuana is an exception. So we do have that data here. So what we can see based on the table is that at the national level, and then for each of the states in the South-Southwest region, past month marijuana use has increased between the years 2016 and 2019. The largest jump in use was seen in Oklahoma, and the state reporting the most use in this region was New Mexico, which surpassed even that national trend level data that we see there at the top. Next slide. Yeah, and I see a comment from Joanne saying New Mexico just approved marijuana legalization beginning 2022. Exactly. So like I said, I think it's going to be, we're going to see lots of different data and probably significant increases over the next couple of years based on states legalizing and then seeing if there's a federal response as well. So great point. So just moving over now to tobacco and vaping trends. In the Southwest region, tobacco and cigarette use has generally been on the decline in most of the states. However, we do see that Oklahoma is the exception to this. So however, while their rates remain high, they did see that the percentage of Oklahoma high school students who smoked at least one cigarette in the past 30 days before the survey decreased by 53% from 2003 to 2017. They still are higher than national averages, and we'll go through some of that data over the next couple slides. But generally it's decreasing, but like I said, Oklahoma is the exception. So this decline follows those national trends, which has generally seen year after year reductions across all age groups. Much like youth alcohol, there's been significant increases at the national, state, and local level to prevent tobacco use, not only for youth, but also for adults. Data in the region shows that youth vaping has increased in each state for both current and lifetime use rates. Again, this matches what we're seeing at the national trend level data, which has really seen that explosion in vaping use rates during the last few years. Increases in youth vaping rates present really sort of this urgent public health challenge, and really has threatened to undo, the decades of success that we've been seeing in reducing youth tobacco use rates. And like I said previously, this may also be helping to drive increases in youth marijuana use. We do see that COVID-19 may have impacted youth vaping and e-cigarette rates, with one study actually showing that there might be a reduction in use. So a study is coming out by Geha et al. Found that in their cross-sectional survey study of just over 2,100 youth and young adults using e-cigarettes, almost 1,200 youth reported changing their amount of e-cigarette use, with 810 of those participants reducing or quitting e-cigarette use. Reduced e-cigarette use or quitting was associated with adhering to those shelter-in-place guidelines that we all lived through, and was less likely if participants had used e-cigarettes more than 10 times or were nicotine dependent. They also found that e-cigarette access shifted to alternative retail stores and online, which also isn't surprising given the shelter in place that has been going on over the last year. So as data comes out, as updated data rates come out, I think it'll be interesting to see how COVID has definitely played an impact on these rates, and whether or not the trends will hold steady based on this one study, or if they'll differ. So next slide, Josh. So when we talk about tobacco products, these include cigarettes, smokeless tobacco, such as snuff dip, chewing tobacco, et cetera, cigars, or pipe tobacco. So looking at past month tobacco product use, we see that rates have fallen for most states between those 3 years, 2016 to 2019. Texas had the largest decrease with almost 2%, and Oklahoma was the only state to experience an increase in past month tobacco use for those aged 12 plus, but they saw a minor increase during that time period of just under 1%. And I know it's been in the chat, and as I've stated previously, the question is about whether or not these are significant. And if you're able to download the presentation, you'll see the resources that we used to get this information. And sometimes the data points, what we're generally showing is trends. Some will be statistically significant, some won't, and some may vary, like I said, again, based on age, different regions, things like that. So I would always recommend doing a deeper dive to test and look at that statistical significance. Next slide, please. So here we're going to look at cigarette use and really doing that deeper dive into tobacco products and parsing out some more information on different kinds of products. And so we're looking at past month cigarette use here. There are slightly larger reductions in use, specifically for cigarettes, in almost every state. Arkansas saw a reduction of 2.1%, Louisiana 1.8%, Texas 1.6%, and New Mexico came in just under 1% at 0.8%. Oklahoma, again, saw an increase in their cigarette use of 0.7%, so a minor increase overall, but definitely something that they'll likely be keeping an eye on. Next slide, please. So here we're going to turn to youth vaping. And so vaping is where we begin to see the larger increases in trends among youths. Using the Youth Risk Behavior Surveillance Survey, which collects information for those in grades 8 through 12, we see that vaping is up several percentage points across the states in the region. Oklahoma saw the largest increase in youth who reported ever using vaping products at 9.2%. And then Texas had the lowest rates out of those in the region, but still saw an increase from 2017 to 2019 of 7.5%. In terms of national data, there is some 2020 findings on e-cigarette use. So in last fall, the FDA and CDC released findings from their national youth tobacco survey showing that 1.8 million fewer US youth are currently using e-cigarettes compared to last year. However, youth e-cigarette use has increased dramatically since 2011, with 3.6 million youth still currently using those products. Moreover, the data is showing really a very large increase in the number of youth who use disposable e-cigarettes, with more than 8 out of 10 youth e-cigarette users reporting use of flavored products. So we still see that this is quite a large issue that we have to tackle. And once we get some more updated data, we'll be able to see even some more trends and if there has been a reduction based on COVID. Next slide, please. We see that the rates for youth currently using vaping products is lower than those who indicated that they had ever tried a vaping product. So on that previous slide. But once again, we're seeing some very large increases in current vaping use between 2017 to 2019, which continues on that trend that we've been seeing over the last decade. Arkansas and Louisiana and Oklahoma saw the largest increases, each around 10.5%. New Mexico came in at just under 10%, and Texas is around 8.5%. And we know that these jumps in use are pretty concerning. The YRBS survey found that 33% of high school students nationally were current e-cigarette users in 2019, which is an increase of over 13% from 2017. So we're seeing that trend both nationally and across the region here. They also found that a third of those youth who used e-cigarette users reported frequent use, so at least 20 days a month, which tends to be a strong sign of addiction. Nearly 11% of all high school students use e-cigarettes at least 20 days a month, compared to less than 2% for regular cigarettes, really kind of indicating that e-cigarettes are now addicting for more kids compared to cigarettes. So one of the questions I have for the chat that'll be placed in there is, what do you think has led to the decrease in tobacco and cigarette use, but an increase in vaping among young people in your state? If you know of anything that you'd like to share. Next slide, please. And so I'll finish up these next couple slides talking about fatal suicide rates in the region. In 2018, at least 48,000 people in the United States died from suicide. It's the 10th leading cause of death overall and has been in the top 12 every year since 1975. For those aged 10 to 34, it is the second leading cause of death. Rates of suicide have been steadily increasing since 1999, and we see that's an issue across all demographics. Research shows us that suicide has no single cause. It's really based on confluence of factors and responses to biological, psychological, interpersonal, and societal influences that interact with one another over time, as well as based on different contexts. Data shows us that individuals with substance use disorders are particularly susceptible to suicide and suicide attempts, with substance misuse significantly increasing the risk of suicide. Suicide is a leading cause of death among folks who misuse alcohol and other drugs. And one of the reasons alcohol and or drug misuse significantly affects suicide rates is the disinhibition that can occur when a person is intoxicated. According to data from the CDC, we see that about 22% of deaths by suicide involved alcohol intoxication, as demonstrated by a blood alcohol content at or above the legal limit. Opiates, including heroin and prescription painkillers, were present in at least 20% of suicide deaths. People with an SUD are at particularly high risk for suicide and suicide attempts. It's, like I said, the leading cause of death among those who misuse substances. Diagnosis of an alcohol misuse or dependence is associated with a suicide risk that is 10 times greater than the suicide risk in the general population. And so for individuals with the SUD, their lifetime risk of a completed suicide is 7%. We also know that more than half of acute psychiatric admissions that involve suicide or suicide risk also involve alcohol or drug use. So there's really clearly some strong links between substance use and suicide. And then many of the same risk factors for suicide are shared by substance use and other forms of violence. These include risk factors such as depression, thrill-seeking or life-threatening behaviors, aggressive tendencies, history of trauma or abuse, feelings of hopelessness, physical illness or chronic pain, as well as relational, social work, or financial losses. Next slide, please, Josh. And so now when we're looking at fatal suicides per 100,000 folks across the Southwest region, we see that there was an increase in New Mexico of around 0.5%, Oklahoma 0.4%, and Texas at 1%, so the largest. Nationally, during this time frame, we saw an increase in suicide by 0.8%. So Texas was the only state to surpass that national average, and the other two states that experienced increases we're about half of what we're seeing nationally in terms of an increase. So they're all kind of within the same, looking at the same sort of trends there in terms of increases. We see that both Arkansas and Louisiana saw decreases in their fatal suicides between 2015 and 2019. Arkansas saw a reduction of about 1% and Louisiana of 0.3. So at this point, I'm going to hand the presentation back over to Josh, and I will be back with you all shortly.
You all are doing really great, Josh and Emily. I'm noticing there's lots of talk in the chat box. And so I certainly want to go back to the question that Emily posed about tobacco. And it seems like there's quite a bit of conversation happening here. So Angela asked, nationally, we've had a huge marketing campaigns directed towards the harms of tobacco and cigarettes. We just don't have the level of marketing about vaping. And so Sean Von Wheeler says vaping is easier to hide than cigarette use with youth. And then there was Emma answered a question about possibly due to the different flavors of vaping has caused the increase of vaping, which caused tobacco and cigarette use. So while we're taking this pause, if you all would like to ask a question about the slides you just saw, please do, because the last part of our presentation today will be about strategies. So what questions do you all have about the data that you all have seen today?
Thanks, LaShonda. Yeah, and I'd also note that in the interest of time and to make sure we have a chance to answer your questions, we're just going to briefly be going through some of the remaining slides in this presentation. Unfortunately, we just don't have time to cover all of them, but I will note that if you are interested in hearing more about the topics we're going to talk about, well, we're planning to talk about for the rest of the webinar around variations in trends and strategies. One resource you can access is the previous webinar that Emily and I did for the Central East PTTC on March 10th called Understanding and Addressing the Social Determinants of Health in Prevention. And a recording of that is available on the sort of overall PTTC website. And in that, we talk in a much greater detail on some of the topics we're only going to have a chance to briefly touch on in our remaining time today. So I just wanted to plug that. So as people do continue typing in the chat, and we will turn back to it, as I said, I'm just going to very briefly cover some of our remaining content, which was first of all, what can cause trends to vary. So the two main ways we can think about that are through risk and protective factors and also through the social determinants of health. I think a lot of folks are probably already pretty familiar with risk and protective factors. I wasn't planning on spending too much time talking about it anyway, but just a very brief reminder, it's the idea that there's a variety of different factors in our lives that influence the likelihood we would engage in any sort of risky behavior, including substance use. And these factors can be organized into what we like to call the socio-ecological model, where we have our individual level factors, our relationship level factors, our community level factors, and our societal level factors. And historically, a lot of prevention, particularly all the behavioral interventions we do around changing attitudes and values and beliefs, a lot of them have focused on individual and relationship level factors, including building up life skills, those kinds of strategies as well. In past several years, there's been a greater focus on implementing environmental strategies to better focus on those community and societal level factors. And then in addition to these risk factors, there's this other concept called the social determinants of health, which are sort of another way of thinking about community and societal level factors, but they're actually more than that. The social determinants of health, as defined by the US Department of Health and Human Services, are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And they are organized across 5 different domains, which are education and access and quality, economic stability, healthcare access and quality, neighborhood and built environment, and social and community context. And the thing about the social determinants of health is just that they are really big picture aspects of life. Sometimes they're too big for us in prevention to address on our own, or even at all, other than raising awareness of them and their importance. However, We can play an important role in prevention by being part of an overall public health approach that's focused on the social determinants of health and improving overall health and well-being through large-scale policy changes and multifaceted strategies. And by being involved with these stakeholders, we can, as I said, improve people's overall health. And in addition to that, even if there aren't necessarily opportunities for us to impact the social determinants of health directly, it's still important for us to learn about them because they influence the landscape that we're working in. So, we always want to know about all the factors influencing people, even if we can't directly impact some of those factors. So these next few slides go through those in more detail, but as I mentioned, we unfortunately don't have the time to go through them right now. I will note that there are, as I mentioned, sort of these large-scale strategies that go along with a lot of these factors. Like, for instance, with healthcare access and quality, one big strategy is expanding access to health insurance coverage. It can be hard to find a role for prevention to play in that, but it's not necessarily impossible. For instance, a prevention entity could partner with another public health entity to get a navigator grant, which are these 8 grants from HHS to explain to people what their health insurance options are and get them better enrolled in coverage. And we want that because health insurance coverage is strongly associated with better affordability and access to care, which is itself associated with reduced rates of substance use. So that's just a brief example there. And as I said, we have that whole other webinar where we talk all about this content. To wrap things up, I'm actually going to turn things over to Emily now to talk a little bit more about prevention strategies for the region, focusing a little bit more on sort of behavioral and environmental ones rather than those really big picture social determinants of health strategies, but it's important to learn more about those as well when you get a chance. So thanks. Emily?
Great, thanks so much. Hi, everyone. I'm just gonna review these next 2 slides with you. So when we're talking about prevention strategies for the region, we know that individuals don't become involved with substance use solely on the basis of personal characteristics. They're influenced, all of us are influenced by a complex set of factors, such as institutional rules and regulations, community norms, mass media messaging, as well as the accessibility of things like alcohol, tobacco, and other drugs. So some strategies that you can implement in the region look at 2 different but combinable approaches. And the first would be environmental strategies. So grounded in the field of public health, which emphasizes that broader physical, social, cultural, and institutional forces that contribute to problems, environmental strategies incorporate prevention efforts aimed at changing or influencing the community conditions, standards, institutions, structure, systems, and policies that are in place. So it's really about changing the context, so that environment in which substance use and abuse occurs. And then when we talk about behavioral health strategies, these are the strategies that really are trying to change sort of more at the individual level, right? So they're trying to change attitudes, perceptions, values, and beliefs in order to discourage and prevent substance use and misuse from occurring. A really important part of behavioral health is recognizing that mental health, as well as alcohol and other drugs, go hand in hand, and that they can influence each other and that they're impacted by each other. So that's sort of one thing underpinning a behavioral health strategy approach. So we're really looking at environmental strategies, which kind of look at sort of the larger pieces and pictures of the puzzle, and then behavioral health strategies that focus a little bit more on that individual or at least smaller community level, trying to fight back against those individual held perceptions, values, and beliefs. So for behavioral health strategies, this could include something like early intervention services, which could be provided in a variety of settings, right? Schools, primary care offices, mental health clinics, et cetera. And so early intervention really consists of providing information about substance use risks, normal or safe levels of use, and strategies to quit or cut down on use and use-related risk behaviors, as well as facilitating patient initiation and engagement in treatment when needed. So that might be, that's an example of a behavioral health strategy, is doing that early intervention. And then when you look at both of these interventions, components of them include education, right? So you want to educate the community about substance use and what's going on. What are the harms? What's the prevalence in the area? What can be done about it? You also want to educate healthcare providers so that they can respond with the most appropriate treatment. Also first responders, so that they can recognize when someone is engaging in a substance use or mental health crisis and get them to appropriate care. Another component is policy. Policy change is really essential here, and why you want to kind of implement all of these things together. And the policies really should be based on the needs in that particular community. So this can range, there's a variety of different policies that you can look up, and I'll go over some additional resources on the next slide. But this would include things such as increasing alcohol prices. It could be a needle exchange program. It could even be a DUI court. So there's a variety of different policies that can happen, local level, state level, and then we even see some at the national level, obviously, as well. And then another critical component is training. Training is really essential because it allows for the effective implementation of a program or strategy or intervention, which can really increase the changes that it's able to make, as well as the efficacy of those changes. So is it able to change what it's intended to do? And then additionally, overdose prevention strategies have been utilized as we've seen advances in medicine to address that particular crisis in terms of overdoses. We know that naloxone is available for opioid-based overdoses in a couple of different forms, as an injectable, auto-injectable, and as a nasal spray. And as Josh touched on earlier, while methamphetamine overdoses are serious and are a rising issue, right now we don't have overdose medications currently available to address it, but research is ongoing, and NIH just announced some new funding in March specifically for that. So a chat or poll question that we have is, what types or kinds of prevention strategies has your state or local community implemented that has been utilized successfully? Which ones have you found been the most successful in actually targeting the issue? So if you have any that you know of that you've implemented, feel free to put that in the chat, because I'm sure it will be helpful to all the other folks in the region. Next slide, Josh. Thank you. So here are some websites that you can use and some resources to try and find some evidence-based programming that will meet the needs in your region and for your specific communities that you're trying to target. So we have the Evidence-Based Practices Resource Center, which is a collection of scientifically based resources for a broad range of different audiences. Blueprints Program Registry. So this is a comprehensive registry of scientifically proven and scalable interventions, which you might find helpful. And then we have the Athena Forum, which provides information on direct services and environmental prevention strategies as well. Furthermore, one thing that you could do, and this is a part of a series of presentations Josh and I did for the Central East PTTC, is to use SAMHSA's Strategic Prevention Framework, so the SPIF. And I would recommend consulting the SPIF kind of before you even go off and access these other resources, because you can really implement it, before, during, and after you would want to bring a program or strategy into your region. This SPIF consists of 5 steps and has 2 guiding principles that can offer prevention planners, a comprehensive approach to understanding and addressing the issues in your community and how to address it. So it focuses on assessment, what's the problem, capacity, what do you have to work with, what's the funding, what's the local resources that you can use, et cetera, planning, what should you do and how should you do it? So finding some of these interventions that we have listed here on the screen, implementation, how can you put this program into practice and make it successful? And then the last piece, which is really critical, is evaluation. Is the plan succeeding? If not, what can we do to fine tune it to make sure that you're really getting, the best bang for your buck? You're actually addressing the crisis and the issue in the area, and making sure that perhaps the program that you're using isn't causing any more problems. So at this point, that's all I have for you all today. I'm going to be answering your questions in the chat as best as possible, and I'll hand it back over to Josh. And I just want to say thank you all again for your attention and for just including amazing information in the chat today.
Thanks, Emily. Hi again, everyone. So I apologize for us having to rush through things a bit at the end here, and because of the tech issues we had at the start of the webinar, which again, I think are probably my fault. Hopefully we still covered all the content in a useful way for you. And as I mentioned, the slides will be available after the download is over, after the webinar is over. So that actually wraps up our content for the day's webinar. So I want to give you all another chance to ask any questions you have of us. I think there might also be an evaluation that the PTTC wants you to complete, ideally. And yeah, I can just, LaShonda, let you introduce that.
Thank you so much, Josh and Emily. We certainly appreciate your time today. As Josh and Emily have shared, that the materials and resources will be available to you online for certain, and we'll make sure that each of you who have registered will get it in your email. Please, please, please fill out the evaluation for today's webinar. It's important to us. We're working on a federal grant, just like many of you, so there's some nose counting that has to happen. But we certainly always want to fine tune the services that we provide you all here in the South Southwest. And the best way of fine tuning those services and making sure you're getting what you need is to have you all complete an evaluation, and for us to review that evaluation and make sure that we are calibrated just right to meet your needs. I appreciate you all today, and look forward to seeing you all at other webinars that we have. Look out, because in the next few weeks, we are going to have a logic model webinar. So you heard a little bit about the SPIV, now that we've talked a bit about strategies, where does that plug in into your logic model so that you can truly get to outcomes? So anyway, you all take care, and thank you all for joining us this morning.
Thanks, everyone.
Thanks.